Welcome everybody. I will now start introducing the topic with like a brief summary of what we are going to speak about. So basically, my seminar is not only about antibiotic resistance, but it's more on the cost accounting of antibiotic resistance. So I will not deal with the specific biological and medical specification of it. But only on the economic part. I'm starting working in this very interesting topic because we realized here doing some project on antibiotics that there is a shortcoming in this specific area of economic implication of antibiotic resistance. And since, as we already know, antibiotic resistance is one of the main problems in the future, also according to World Health Organization, we thought that it's worthwhile to have a better look at the issue. Probably during this week, at least it happens to me because on LinkedIn I saw many figures, many graphs about the spread of resistance over the year. But here, and so maybe also you had the opportunity to saw that. But here I include this graph that I thought more insightful, because it's not only about the spread of resistance, but it's more about the average time to develop resistance. And I think it's very interesting to see the difference in the last few decades, because actually what is happening now is that also in the past, of course, we had resistance, but the point is that they were able to improve and make innovation in the antibiotics. So they had new antibiotics that can overcome the problem. But now, since the average time to develop resistance is much shorter, this is more, of course, problematic to find new innovation and new drugs in the field, and so that's why we are here. I mean, economic valuation can work to this problem in the way we will see in the next slides. So the objective of today, in general, is to show you the economic consequences of the antibiotic resistance, and I will do that in a different way. I will start providing some very simple and generic notion of economic valuation. Then we will see why actually we have this shortcoming in the cost evaluation of the resistance, and then I will present also how we possibly can overcome this the shortcoming and try to make an estimates of the resistance cost. That at the end, of course, we will use for public decision making. It's because what I find interesting in this topic is that it's not research by itself, but it's really something that we can apply to public health. So, as I said, I will now introduce a bit of health economics and economic evaluation in this perspective. So, as it's important to underline, economics is not only about money, but is especially about the use of scarce resources. And this is very important because it's not about cost savings, because I had this discussion many times when I told that I'm an health economist. A lot of people think that is about saving cost in the healthcare system, but actually is not. I mean, it can be, but it's not only that, because as I said, economics is about scarce resources, and one of the most scarce resources we have is, of course, health. So health economics try to combine the economic perspective to the health perspective, especially to see how to allocate resources from a public point of view in the health and healthcare of population. So we have to both consider these two aspects, the health, the public health part, and also the economic part, because resources are not unlimited. So of course we have to make decision to try to allocate them in the best way. To do that, we need economic evaluation, because with this branch of economics, we can use some techniques and methods to evaluate and estimate the effects of each policy, progress, program, innovation, drug, and in this way we can really see. I mean, we can really predict, because of course then some unpredictable can happen, but it's always important to at least predict and try to estimate what can happen. And so that's why I will use this economic evaluation approach. In a nutshell, what economic evaluation does is to, as I said, try to find the best way to allocate the resources. That means that we want to pick and choose the best project. And what are the best projects? In this welfare economics view, a good project is a project that improves social welfare, and this means basically that the benefits overcome the costs. And of course, when you have to deal with a specific problem, you have different solutions, and economic valuation helps to find the best solution to each issue, comparing the different alternatives. So at the end, what we want is basically to find total value, total impact of the project, to rank the desirability of each intervention. Of course, I mean, I think that the idea is straightforward, because of course we want that the benefit are higher than the cost, for sure. That's how every people want to make decision. The problem is that since we deal also with the intangible, or what we call non-monetary values, it's a bit tricky, because for example, about direct cost, it's very easy to estimate the direct cost, because we have just numbers of the cost, as I said. While if we want to see also the benefit that in our perspective are the health benefits, it's not easy at all, because health is not something that is usually expressed in monetary terms. So in our case, in health economics, we have always to deal with this problem, but we have to keep in mind that it's always a controversy, because it's not easy to find the right way to translate into money. That it's what we call monetization of the effects. It's not always simple to monetize the effects, the health effects, into money. What we also have to keep in mind is that yes, it's true that the total impact on welfare is the main driver in economic evaluation, but it's not only because our total net impact is positive, we must go with the project, because can happen, for example, that the distribution of the effects of the policy or the program under evaluation are not equally widespread in the population. So it can happen that we have a part of the population that is positive affected, and a part that is negative affected, and also this fairness and equality issue is something that we should keep in mind when we rank the desirability of the project. And this is particularly important, of course, when we speak about health and public health, because we have problems that are most of the time regional and not equally widespread also in the population, because maybe we have some disease that is more for the children, one is more for the elderly. So it's not always simple to take into account all the fairness problem. Here I summarize the three main methods that we use in health economics. I will be very quick, because the presentation is not only about that. what is used normally is cost-benefit analysis in general when we want to assess public projects. But the problem of this that is a very helpful technique, but the problem is that when we apply it to healthcare and health problem in general, is that we have to monetize these effects, and it's always a bit tricky because we have to make assumptions, and the more assumption we make, of course, the more risk we have to make some errors and to not be super precise. But it's always a good method because with this we can compare also very different projects. We have the same metrics for all of them, so it's quite easy. What is used in health economics normally is cost effectiveness analysis, in which instead of just comparing the in monetary term the cost and the benefit, you basically consider the ratio between the cost of the intervention, so let's say the cost of a specific treatment, and also the effect of the treatment that now is not in monetary term but is expressed in a health indicator. For example, for antibiotics, we can have the prescription rate. So if we study the effects of a new policy about antibiotic prescription, we have the cost of it and the effect on the prescription rate. A combination of the two methods is cost utility analysis. That is again a ratio between the cost and this benefit, but the benefit is considered not as a health indicator, but is more general indicator about the well-being in general. It's what in economics we call utility. And in health economics is expressed usually in quality adjusted life years or disability adjusted life years. That means basically, maybe you already know, it's when we want to consider not only the number of years gained or lost due to a new intervention, but we want to adjust them by the quality of the years you gain, because you can have a treatment that can keep you alive for many years, but the quality of your life is very low, and so with this quality indicator, we can take into account both the aspects. Also, what is important about cost utility is that since we have this general indicator, the quality, usually in quality term, it's not disease specific as it happens in cost effectiveness analysis, but we can compare even treatment in different areas. So now that we have this in mind, we can focus on the main problem we are dealing with, that is antibiotic resistance. So as you know, the main driver of resistance is the overuse of antibiotics. That could be over prescription or over consumption. It depends. And of course, this over consumption is responsible for developing the resistant strains, because the bacteria reproduce in such a way that they can survive the drugs, and so they become more resistant, and that's why we call resistance to antibiotic, because they resist to the effects of the antibiotics. So in general, what it's important to keep in mind is that the more antibiotics we used, the more we are likely to have an increasing resistance. Of course, it's important to consider that what we are seeing is not to avoid antibiotics at all, because antibiotics are actually very important. They can save millions of lives every year. What we are saying is that we should decrease the over consumption, that is the useless consumption, that is the over consumption, so what it's more than the needed. Here I put this nice table to summarize the main causes of resistance. As I said, overprescription is the main one, but of course also not considering the right indication by the physician is also a problem. And what we have to keep in mind is that antibiotic resistance doesn't develop only the human level, but we have it also in animals and because in the livestock, for example, but also in the fields and in agriculture, because antibiotics are used, of course, to treat animals and also to keep, for example, some lands more clean, let's say. So it's important because if we only focus on prescription on humans, actually we are not dealing with the all of the aspects about the problem. Also, I want to underline here the last figure is the lack of rapid laboratory test. This is quite interesting because, as we will see, I did a study last year exactly about this, and we will see that it can be a nice way to deal with nice and easy way to deal with the problem. So here we have the consequences. Of course, since when we have a resistant infection, it's more difficult to treat it. Of course, we have an increase in mortality. As we have an increase in the, for example, duration of the disease or in the severity of the disease, and all these aspects, of course, go in the increase of healthcare costs, because if we have to deal with more hospitalization, more care, more works by the nursing and physicians, more drugs, more treatment, of course, we have an increase in the costs. And this is very important in a public perspective. And last but not least, we have also this intergenerational and regional unfairness, because as we saw, antibiotics resistance now develops much quicker than in the past. So we have to keep in mind also for the future generation. And basically, it's now that we have to move and to find solution. So all of these aspects, of course, contribute to this socio-economic burden. The problem, of course, it's quite straightforward to see that we have a socioeconomic burden, but still we have we lack of estimations, and we will see in some slides why and what we could do. Here I put this graph because it's quite interesting to see the distribution of resistance during the year. Sorry, not during the year, during across different areas. We will see during the year in the next slides. And in the previous slides, I told that we have these regional differences in the regional distribution, and here it's quite easy to see. For example, in some sub-African country, this problem is it's much bigger because they still have problems with some particular disease and infection, so they are using a lot of antibiotics there, and that's of course contribute to the resistance. Here I just show this. I'm just showing this map because it's easy to visualize that. As I said, the problem is not equally widespread. In this case, there is a very nice study by Lancet about many different bacteria and antibiotics. I just picked this one because it's quite. The Escherichia coli is one of the most widespread, so it's one of I think most important to show, and as we can see, the distribution is not equal across the different countries. Yeah, and I think it's something interesting and important to consider. So now that we introduced the resistance in general, we can deal with the resistance costs. As I said, we have this lack of information, not because researchers are lazy, but because it's quite difficult to take them into account. For example, antimicrobial and antibiotics resistance is not considered a disease. So in a lot of dataset is not classified with a specific disease. And so that's why it's difficult to have precise estimates of the cost of illness. Also because, of course, when we have resistance, we also we are always in a case of comorbidity because the patient, of course, is affected by the bacteria itself, and also is resistant. But of course, I'm not the first one thinking about this problem. So I saw in the literature that there are many guidelines and many suggestions about how we should include the antibiotic resistance cost in the economic valuation and in public health decisions. The problem is that one of the problems that is always mentioned is the lack of precise and sufficient data, because to be fair, we need a lot of data to be able to estimate precisely the cost of resistance. We have also some studies that try to make an estimations, but honestly, what I found is that we have still a lot of inconsistency between the different approaches used, because as I said, it's not classified as a specific disease. So depending on the methods and on the perspective you are applying, you have different numbers. So, for example, we have a study in the US saying that the cost of resistance is about 55 billions per year, or 1.5 billions in Europe. But you see, it's much lower, and it's a bit strange. Yeah, you can find many of these very rough estimations, but it's not what is useful in the specific decision making to apply. We have a very nice tool that is called Global Burden of Disease. That it's something that in health economics we use a lot to see the impacts and the costs of the different disease. But here, the resistance is included only for tuberculosis and HIV. So we don't have a general overview of the problem, but only in these two specific disease. Just a couple of data that I found interesting. I quickly calculated that in the last 30 years, because we have data between 1919 and 2019, in these 30 years, we have 171 million years of healthy life lost. These are basically the DALYs, and the trend in DALYs is interesting. Is interesting to see that is increasing when we consider the resistance, even if the impact of the main disease is decreasing, because of course we have better treatments, we have more vaccination, for example. So the overall health impact of the disease is lowering, while the negative impact of resistance is increasing. And here we have a graph of the prevalence. So we can easily see that the trends in the last 30 years went up a lot, starting from a very low number. And so of course, as I said, it will be a problem that will even raise in the next few years. So this is basically the state of art of what we have available. And what we can do in health economics research now is to try to estimate precisely the cost of antibiotic resistance. And to do that, I mean, it's connected to the fact that we want to find the optimal prescription rate of antibiotics. Optimal in the sense that is the prescription rate that is minimizing the cost. And once we have these two figures, the one about the cost and the one about the optimal rate, we can apply these findings in decision making and in general in public health decision about antibiotics treatment. So first of all, we will see the estimation of the cost of the resistance. I'm saying right now that I don't have conclusive estimates, but I will show you because of course it's a long process. I'm still in the process, but I will show you what was the idea behind and how we possibly can make it. So one of the main problem about this inconsistency in the numbers about resistance cost is that the methods applied to cost accounting are different. In the figures that I show you about, for example, the estimation in the US or in Europe, they used what is called top-down methods. So basically, you have this general estimation about the average or total cost of the problem, considering the macro effects. But this approach, I mean, it's not that it's wrong. The problem is that in this case, for example, we have many data gaps, so we have to make assumptions when we don't have data, and the more assumption we make, the more likely we are to make some errors and not be precise in the estimations. So while the previous estimation used this approach, I'm proposing now to, I mean, not only me, but also the literature I show you in the previous slides. That is in which they were suggesting to consider this cost accounting and in a different way. So this method called bottom-up approach is apparently better because in this way we are basically considering all the cost items and all the components in the cost, so we can basically identify them and then put a unit cost to all of them. I'm giving you an example. For example, when we want to estimate the cost of a treatment, we consider the medical cost. That means the drug costs, the testing costs. If you use some devices, you consider the cost of the use of the device. You consider the cost of the work of the physician, and so on. So these are the single components of the medical costs, and you consider all of them, and you have a price for all of them. Then you sum up everything, and you have the cost of the treatment in general. And depending, of course, on the perspective you want and the approach you're considering, sometimes you include also, for example, transportation costs, other hospitalization costs, but it's very disease specific and context specific. So apparently it's very nice, and so why we don't always use this approach? The reason is that because we need a lot of data to do that, precise and very precise data about all the components, and it's not always straightforward, especially for resistance that, as I said, is not classified as a specific disease. There is a very comprehensive paper by Morel et al. That in which basically they considered all the possible costs in the antibiotic resistance. So they provide a huge list of direct and indirect cost of all in all the sphere in which resistance is applied. So healthcare for humans, in animals, the treatment of animals, and in environment. As I said, they have a huge list of costs, but here I put just the main ones, because otherwise it's an endless exercise if we consider also all the sometimes even not significant cost, because I don't know, for example, we have to put the cost, we can put the cost of a campaign in the school. Okay, I mean, it's not wrong, but um, it's very indirect. So uh, if we do that, we should consider also all the other costs of everything, and so it becomes a never-ending problem. So we need to be pragmatic. So that's why here I put only these the main costs. Maybe if you're not familiar with economic valuation, I can just explain the difference between direct and indirect cost. Basically, the direct cost, speaking about healthcare, of course, the direct costs are all the costs due to the care and the treatment of a patient. For example, the drugs that are needed, the testing, and so on. While the indirect costs are basically the costs connected to the treatment, but that are not included in the cost of the treatment, and are in this case more about in general the social cost and not the medical cost. Why the social cost? Because if we have a patient that have a long infection, for example, it will miss a lot of activities, both in his profession. So uh, lose a lot of days of working, for example, so it becomes less productive, so it will make less money. But also, of course, it's not only about money, but it's also about the activity that she lost in her own life. So it's also about the cost of basically the loss of leisure that you have when you're sick. And it's quite important because we don't want to be sick, because we don't want to have also this pain problem and so on. So these are the two, basically the main difference between the direct and indirect costs applied to humans. To animals, basically we have almost the same, because instead of treatment of humans, we have the treatment of animals. And also here we have productivity, in the sense that if we have a number of, let's say, cows that cannot produce milk for a while, it's a loss for the companies that have the animals. So it's also a loss for the society, in the sense that they lose productivity. Regarding environment, we have the contamination and this cleaning of possible infected places. As indirect costs, we have loss of tourism and loss of productivities of areas that are affected. So now that we have I hope a clear idea about the cost accounting about resistance, we should keep in mind still that since we have different disease, because resistance is not applied only to one specific infection, but it's in general what we call resistance. It's a general concept. So it doesn't make sense to consider in general the cost of resistance. I mean, we can do that, but only if we sum the cost of resistance for each disease, because for depending on the disease, we have different behavior or resistance, and of course different costs depending of the disease. So what we should maybe deal with, at least now that we are at the beginning, is more considering each disease and the resistance for each disease. As I said, it's important to be pragmatic and focus only on the main costs. Otherwise, it's a bit confusing and it becomes a never-ending problem. And also, what I didn't mention, but it's very important that when we say cost of resistance, okay, of course, there are the cost related to resistance, yes, but we have to compare them with something, because cost of resistance compared to what? Because in general, when we want to evaluate the cost of a new project, we are always comparing the project. I mean, let's say project A with project B, or a new project with the standard of care. So we need the counterfactual all the time to compare and to calculate this incremental cost, because it's the only way we can say, okay, this project is providing a good impact on welfare. But in this case, of course, finding the counterfactual is not very easy, because it depends on many factors, and we will see some of them. We will see some of them in this framework that I'm introducing. In general, in epidemiology and in infection disease, a lot of mathematical models are used to track or to try to predict the dynamics and the behavior of the infections. Probably you saw this approach when we have the COVID pandemics on the TV. They showed a lot of this, the curve of the contagious and the prediction of the peak of the disease, and this is made with these mathematical models that are in general called SIR models. That means susceptible, infected, recovered models. And it means basically that in these models you consider these three compartments, let's say these three categories of people, because you can, I mean, this is the more simplified way, but for resistance it's a bit more complicated. But the general idea is that each everybody can be, I mean, each person can be either in the susceptible compartment, or in the infected one, or in the recovered one. So I'm not going into the mathematical detail, but in general, what we have to know is that solving this system of the equation that are explaining the dynamics of the changement between these different compartments. If you solve these systems, you can know the number of people in each class over time. So again, I don't want to show you in the details the mathematical behavior, but the general idea of the model applied to resistance in this case is that at the beginning, of course, all the population is in the susceptible compartment. Then when you have the infection, you go here in the infected by susceptible bacteria. But the problem is that in the classic model, you have only S, I, and R, that is the recovered. But then, of course, if you develop resistance with the time, you can move from the infection with the susceptible bacteria to the compartment of infected by resistant bacteria. And so basically, we have equation that explains all this behavior, and then when you are infected, you can basically either die or either recover. So when you recover, after a while, you become you lose your immunization, so you can be susceptible of the infection again and be infected again. So yeah, this is the general idea. As I said, it's more complicated than, for example, in the standard SIR model, because we have these two different infected status. susceptible to the antibiotics or resistant. And so it's a bit more complicated for that, but not impossible. So the perspective in general is that we are applying this to the behavior and the mechanism of resistance between people. So it's how the resistant bacteria basically moves between people. It's not at the biological level. And in general, with this model, I'm not trying to be, because of course you can add a lot of more complication and specification, but we want to keep it quite simple, because what we want is to connect it with the cost accounting. So it's not to be 100% precise about all the implication about in epidemiological terms, but we want to have a pragmatic and useful tools. This is basically how the model works, and you can visualize it. I did some numerical simulation just to show you the curves over time, but to do that precisely, we need a lot of data, as we will see. But yes, in general, this is the idea. So at the beginning, this is on the y-axis is the proportion of people. So at the beginning, we have that all people are healthy, basically, we can say like that. And then after a while, depending on the parameters about the infection rate, the mortality rate, and so on, you become you become infected or deaf or recovered. So once we have all the calibration with all the right parameters, we can have a precise estimation over time of the spread of the resistance. We can compare the infected with the susceptible bacteria, that is IS, the yellow one, with the susceptible with the resistant bacteria, that is the IR, the orange curve. Yeah, and that's how the models work. This is the idea. Yeah, just to interpret these results, as I said, we have over time these the dynamics of all these mechanisms between different compartments. And what is important is that changing the parameters, for example, let's say the prescription rate, we can see how the models work, and of course it changes depending on the change on the parameter we did. And so it's very useful because if we want to evaluate a project that aims to reduce the prescription rate of specific antibiotics, we can see the effects in the future. And doing that with this with the comparison between the IS and IR, we can see the incremental number of resistant cases. And so we can have this incremental approach that, as I said, it's very important in health economics. But the problem is that to do that very precisely, and that's basically why they didn't do that until now, it's that you need a lot of different data, because imagine that this is only for one disease. So if you want to do it for resistance in general, you have to consider all the possible disease and really a lot of different parameters. For example, the length of infection, the mortality rate, the infection rates, how quickly the bacteria become resistant, and so on. So it's quite complicated because you need a lot of data. Just for an exercise, we can, of course, you can consider all the costs, all the possible costs, but we identified these three main costs: the healthcare costs that are direct, and also the loss of productivity that is indirect. And also, what is important is the value of lives lost, because as I said, it's not only about money, but it's also about the increase in mortality. So if we have more people with a resistant infection, they have a higher probability to die. So we have a loss of lives, of course, and we have to take into account. So applying the cost to both the scenario, one in which we have more resistance and one in which we have less resistance, we can have this incremental costs. And basically, this incremental cost is the burden of resistance. So it's the cost of resistance. So what is nice of this approach is that we can apply to the same model. We can apply it to many different diseases, changing, of course, the specific parameters. But on the other hand, we have this problem in finding all the data. As I said, connected to the cost estimations, it's also important because the cost estimation is what we call a positive approach. So we want to know we want to estimate the costs, but we also can have a normative approach. That means that in which we want to see what you can do, and what we can do basically is to find and to suggest the optimal prescription rate, and we can use this number for policy making. The optimal prescription rate in this sense is the prescription rate that minimize the total costs. So once we have the cost function, the value of a prescription that minimize the cost is the optimal prescription rate. Yeah, I put a very simple graph just to show you the idea, because what is important is that, and we try to do it with the model, is that if the prescription are too low, then the costs are actually higher. Here you can see in general how a cost function could work in this case. And at the beginning, the costs are higher because if you prescribe less antibiotics, you have more infections, of course, so you have more treatment cost at the beginning. But then if you prescribe too many antibiotics, then you have the risk of resistance in the long term that increased the costs again. So it's important to mathematically derive this minimum level, and it's what we will do for when we will apply the model. Yeah. So we can move to the very last topic, that is the application of the cost of resistance in economic evaluation, in economic analysis. As I said, the idea of all this project was born because I struggled in finding a nice estimation of the cost of resistance when I was doing the project about antibiotic prescription. So once we have the cost of resistance for a given disease, we can then apply this cost in the cost accounting when we are doing the economic analysis regarding the treatment and policy about this specific disease. So can be, as I said, a very broad policy about prescription rate in general, but also clinical trial in which you want to know the possible cost. So you can apply this number. Otherwise, if you don't consider the cost of resistance, you have only the treatment cost. But as I said, at the beginning, you have all the treatment costs. The cost of resistance is something that you have in the future. So if you don't consider it in the analysis, you have basically wrong results. I mean, not wrong. It depends on the perspective, because if you have a 1 month or 6 month perspective, it's perfectly fine. But if you want to consider the effects in the future and the cost and the effects of the intervention in the longer term, you should also take into account the resistance that can raise in the future. So a concrete application of this cost of resistance is, for example, in the project I did about testing for antibiotic prescription regarding lower respiratory tract infections. We did this clinical trial in Switzerland, multi-center actually trial, which we considered the standard of care. And also two different arms. One is the procalcitonin testing, and one is the lung ultrasonography, to see whether applying these two tools separately or together, we can have an impact on the prescription rate. And we found that actually both the methods, both the solution can decrease the prescription rate. The problem is that when I had to calculate the costs, and in this case avoided costs, because if we consider that the prescription are decreasing, of course we have less resistance. But I wasn't able to do that precisely because I didn't have this specific cost of resistance. So I just consider the cost that were available. So, for example, the treatment cost and the medical cost basically, and the productivity loss, but not the cost due to the resistance. So, if we want a precise estimation of this, we should also include the cost of resistance. So, to conclude, and I think we are perfectly on time. What is important, and what I said at the beginning, is that antibiotics are not a problem per se, because they help to treat a lot of people every year. The problem is the overprescription, because it's with the overprescription that we have more resistance, and in which basically the cost overcomes the benefit of using the antibiotics to treat people. So since we all know that resistance is a problem, especially in the future, it's important to try to make an estimation of the cost. But honestly saying, we are still a bit far from this, because we don't have this kind of bottom-up approach in cost accounting. So it's something that we will try to do. But at the end, the problem is always to find the right data and to have all the information available to make the estimations. So thank you for your attention, and I hope it's a bit clearer the approach we use in economics to deal with the antibiotic resistance. Thank you.